Bismillah ar-Rahman ar-Rahim. Welcome in this meeting of CME Continuous Medical Education Meetings of Egyptian Society of Nephrology and Transplantation. Today, our topic is in hemodialysis. Once we talk in hemodialysis, we are usually honored with the presence of our great professor, Professor Hisham al-Sayed, who is the Egypt expert of hemodialysis. Professor Hisham al-Sayed is our moderator today. He is the professor of nephrology and internal medicine at Shams University. He is also the vice president of Egyptian Society of Nephrology and Transplantation. Professor Hisham is the leading of African chapter of hemodialysis in Afghan committee. And now he is the president of National Kidney Foundation. And we are waiting the celebration for the Kidney Day on coming Thursday and tomorrow, starting from tomorrow in Egypt, by the leading of Professor Hisham, today as the president of the National Kidney Foundation. Our speaker today is Professor Yasmine Naga, associate professor of nephrology and internal medicine at Alexandria University, and she will speak about the topic of the dialysate and its impact, clinical impact, continuing our clinical talks and topics in hemodialysis, which is started by the uremic toxins, hemodialysis membranes, and the hemodialysis prescription. And I will leave the floor now to Professor Hisham to introduce Professor Yasmine and to lead this meeting. Welcome, Professor Hisham, and we are honored to have you today.
Thank you very much, Professor Dr. Yasser, my brother. And we are honored to be with you today. And every Wednesday, you are achieving a very great success in the field of the CME. And you are driving the forces of the scientific material. Really, I appreciate that. And all of us appreciate your effort.
Thank you. Thank you.
And today we have Professor Dr. Yasmine Naga. And exactly we can say that the apple falls under its tree. So today our apple will be Professor Dr. Yasmine Salah Naga. So we are sure that we will enjoy a huge material of scientific, especially that in the field of dialysis, you are the home of the expert. So let us go, and then we keep in mind that we have to make some discussion after your fruitful end. Please, Professor Dr. Yasmine.
Thank you, Professor Hisham, and thank you, Professor Yasser, for carrying on the habit that was started by the late Dr. Hussein Shaisha after the COVID of the weekly online meetings. ربنا يعني يرحمه ويرحم كل أساتذتنا اللي فقدناهم في السنة اللي فاتت. And I thank the Egyptian Society of Nephrology for continuing this very fruitful and useful activity. It's an honor also to be in the company of Dr. Hisham al-Sayed, a pioneer and an expert in dialysis. I would like to first declare that dialysis is not my area, but it was very interesting to prepare this talk about dialysate composition. We often miss that, and I found that we can do a lot in the dialysate composition and its prescription to help our dialysis patients. This is going to be the outline of my talk. I'm going to talk first, give a bit of an introduction, then I'm going to talk about the constituents of dialysis one by one briefly, and then I will conclude. First, the major aims of dialysis, of course, is adequate toxin and phosphate removal, which we measure continuously by the adequacy of dialysis, and we pay much attention to it. But also one of the major aims of dialysis is to normalize plasma electrolytes and mineral concentrations, and at the same time to minimize wide swings in the patient's intradialytic plasma concentrations. So the goals of dialysis mainly is to achieve adequate sodium and water removal, preventing intra and interdialytic hypotension, and as well as volume overload, maintain stable pH in the body fluids, allowing appropriate protein and membrane function and protecting the bones, avoiding both hyper and hypokalemia to prevent life-threatening cardiac arrhythmia, and to maintain optimal and calcium concentration, calcium and magnesium concentration to protect the cardiovascular system and bones. The dialysate circuit in the machines is something that we often don't see and don't appreciate. It receives the purified water from the water treatment unit, heats it, deaerates it, and then the proportioning system of the dialysate circuit mixes the water with the two concentrates, the acid concentrate that's usually provided in jerrycans, and base concentrate that's provided either in bags or in capsules. Then after the proper mixing by the proportioning system, the conductivity monitor checks the concentration of sodium in the dialysate. A temperature monitor checks the temperature if it's set to the temperature that's set on the machine. And then the dialysate passes through the dialyzer, and the spent dialysate then goes down the drain with a blood leak detector to check if there is any blood leaking into the dialysate. The dialysate solution contains levels of electrolytes similar to the extracellular fluid, with the exception of the buffer bicarbonate, which is higher, and the potassium, which is lower, and it's almost isotonic. Its usual osmolarity is about 300 milliosmol, while the plasma osmolarity is 200 milliosmol to prevent hemolysis. The solution usually contains sodium, potassium, calcium, magnesium, chloride, and bicarbonate. And in some areas, it may contain glucose or dextrose, but as far as I know, there is no glucose-containing dialysate in Egypt. And the dialysis proceeds by either by diffusion over time with the passage across the semi-permeable membrane, across the concentration gradient. And the longer the time and the more frequent dialysis, the more the diffusion is effective. But we also miss that part of the electrolyte movement goes with convection with the ultrafiltrate. They are small solutes that can move with the ultrafiltrate. So diffusion is not only at play, but convection is also commonly at play. Now, the passage of the blood or the diffusion between the blood compartment and the dialysate compartment, mainly there are some toxins that are present in high concentrations in the blood and that are not present in the dialysate, and we aim for their removal. And some of the other molecules that are present in the blood, especially if the filter is hypor, may pass inadvertently together with the dialysis. And we want to normalize potassium and to normalize bicarbonate. So as we said in the dialysate, there is too low potassium and too high bicarbonate to correct the underlying hyperkalemia and the underlying acidosis. But mainly the rest of the electrolytes, we want to keep them at a homeostasis or at a constant level, so we don't want a lot of shifts in them. Unfortunately, in Egypt, as far as I know, again, we have mainly two concentrates, the green concentrate and the red concentrate, and some of the dialysate composition in them is of the electrolyte composition is not ideal, and we cannot modify it sufficiently. And the bicarbonate again is present either in bags or in capsules. But we'll talk about the constituents one by one and how the ideal compares to the solutions available. First, we'll start with the dialysate sodium. Again, we can only, because we are providing the dialysate through these two concentrates, the concentrate A and the concentrate B, we can only change the sodium concentration and the buffer concentration through the machine. So the dialysate sodium, it is the most abundant electrolyte in the dialysates. It's present in both concentrates. So one concentrate contains sodium and the other concentrates contains sodium bicarb. So it's present in both. And it plays a major role in tonicity, fluid balance, and blood pressure control. And it's removed during hemodialysis by both diffusion and convection. And there has been, over the years, an evolution in the dialysate sodium level. So in the beginning of the dialysis, the aim was to maintain, to prevent hypertension, to prevent volume overload. So they set the dialysate at very low levels. But then as the dialysis became shorter and there was more rapid and effective volume removal, patients started to develop symptomatic hypertension. So the dialysate concentration increased gradually. More recently, it's in many areas, it's mainly set at 140, but there is now wide variation as we now find that the sodium concentration should be tailored to each patient according to his baseline sodium and according to also his volume status. The problem with low sodium that was prescribed in the beginning, that during dialysis, both sodium and urea together with water are removed by the dialysis and by the negative TMP. That leads to, when we lose both urea and sodium, the main constituents that make up the osmolarity of the extracellular water, then there will be decreased osmolarity in the extracellular water, leading to cellular overhydration and disequilibrium symptoms. While I found that if we increase the sodium, there will be some sodium back diffusion as urea is removed during the dialysis, so that it can maintain stable osmolarity. However, if we set dialysate sodium higher than the serum sodium, there will be complications and there will be increase in post-dialysis serum. And also, if we set dialysate sodium below the serum sodium, the baseline serum sodium of the patient, there will be loss of sodium and there will be decrease in the post-dialysis sodium. So as we said, decreased post-dialysis sodium will lead to decreased osmolarity, leading to disequilibrium symptoms like including fatigues, muscle cramps, headache, orthostatic hypotension, and intradialytic hypotension, leading to inadequate ultrafiltration and volume overload, and a decrease in ultrafiltration volume, leading to myocardial ischemia, worsening left ventricular hypertrophy, increasing morbidity and mortality. But on the other arm, also, if we increase the dialysate sodium and the post-dialysis sodium will be higher, there will be increased thirst, leading to increased intradialytic weight gain and increased sympathetic tone. And although we tell the patient don't reduce the sodium in diet and don't drink too much water, because we are putting too much sodium during the dialysis, already he is going home with increased thirst and will be prone to have increased intradialytic weight gain. Again, intradialytic weight gain, it will not allow sufficient volume removal, and it will, the high ultrafiltration rate will lead to intradialytic hypotension with volume overload persisting even after the session, leading to hypertension, left ventricular hypertrophy, and also increased morbidity and mortality. So we have to find a balance and to be in the prescribed sodium, be closer to the serum sodium. Until 2012, the DOPS showed in this analysis that the dialysate sodium is actually very divergent, and there is no unanimous prescription in most countries that were part of the DOPS data, and most of them actually were prescribing sodium that is considered to be too high. And even in 2020, in this article, Prickle-Bauer stated that recommendations for dialysate sodium continue to be based mainly on pathophysiologic consideration, limited observational data, and expert opinion mainly. And there are few outcome trials that do not study the subject completely to assess dialysate sodium. We also have to assess it in relation to the serum sodium, in relation to the volume of the patient, and the presence of hypervolemia, the presence of hypertension, hypertension.
Please mute all. Please mute all. Please mute all.
And also, Prickle-Bauer states that some dialysis facilities still use fixed dialysate sodium concentrations, while others individualize dialysate sodium, and that there is no evidence that either strategy has proven superiority. To add to the problem and to the fact that we don't know enough about sodium balance and how to set the sodium, there have been recent evidence from space medicine and from sodium MRI that found that the extracellular sodium that is osmotically active and that we measure and that we often frequently refer all the sodium balance to is only part of 3 compartments: a slowly exchangeable pool of sodium located in bones, extracellular sodium, which is osmotically active, and there is the tissue sodium that has been discovered, recently discovered. It's water-free storage in the interstitium, in the skin, in the muscle and atrophy, in the arteries, and it's gaining a lot of recognition that it is part of the exchangeable, the easily exchangeable sodium pool. And while extracellular sodium has hemodynamic and tonicity effects, controlling volume, cardiac output, blood pressure, tissue perfusion, and controlling extracellular tonicity, body water distribution, and body fluid volume, tissue sodium is actually also a very important storage buffer where sodium can accumulate, and also this storage affects local hypertonicity and sodium clearance and may have a lot of implications in disease, including muscle wasting, cardiac and vascular remodeling, insulin resistance, aging, and diet. In fact, as extracellular sodium has been linked to fluid overload, hypertension, and cardiac disease, tissue sodium is being increasingly linked to inflammation, muscle wasting, insulin resistance, cardiac disease also, and kidney disease, as well as aging. And tissue sodium in studies that examine tissue sodium in dialysis patients found that there is a large amount of sodium stored in skin and muscles in dialysis patients, and it can be removed, or part of it is removed with dialysis. And this very interesting picture from Lemoine et al. Studied patients with a dialysate of 137 milliequivalent and dialysate of 140, and found that skin and muscle storage actually is higher in patients who are subjected to higher dialysate, even if the serum dialysate is not very comparable or is comparable. And skin and muscle sodium storage may correlate with, in some studies, with blood pressure, fluid balance, and left ventricular mass. So actually, we are not achieving the zero sodium balance, which should be the goal of our dialysis, to remove the exact quantity of sodium and volume that has accumulated in the interdialysis period in order to reach the zero balance. Because although we set the sodium the same for each patient or the same for all patients, we do not, sodium load and sodium to water ratio changes from patient to patient, and even in the same patient, depending on the sodium intake he's taken during the interdialytic period. And always we do not account for the tissue sodium that is being increasingly recognized. So actually the amount of sodium and water removal during each session should be individualized. We also, when we are prescribing sodium, we have to take the volume status into consideration. And extracellular volume is usually higher in hypertensive patients, but sometimes hypertension and even clinical examination of the patient to detect edema are not clear. So in heart failure patients will be overloaded, but they may have high or low blood pressure. Patients with hypoalbuminemia, increased vascular permeability, they will look overloaded, but they will actually be intravascularly depleted. In patients with old age and comorbidities, there's difference in the vascular response to fluid loading, and hypertension can often even happen with volume overload as well as volume depletion. So Cano et al. In 2019, in a very interesting article, said that there should be, for our dialysis or sodium prescription and the sodium and water handling, we should concentrate on 3 areas. First, that we should accurately assess fluid and volume status through clinical parameters and clinical assessment like dry weight and vital parameters, and sometimes even postural hypotension may help, as well as the patient perception and when he feels well. In addition to by bioimpedance to lung ultrasound, IVC diameter, relative blood volume contraction, echocardiography, and maybe also other parameters like BNP and pro-BNP, as well as copeptin, and also sodium MRI may help in identifying the actual sodium load in the patient. A very important part of caring for our patient should be the dietary counseling to reduce sodium in those with high intradialytic weight gain, to preserve residual kidney function as much as possible. In patients with residual kidney function, we may even prescribe diuretics to reduce the volume load. And we should also aim for adequate removal of excess salt and water through individualizing the time, the frequency, and the modality of the dialysis. And there is the increasing use of automated and controlled sodium balancing module embedded in the hemodialysis machine, and evidence on it that it can measure the dialysate sodium coming in, the dialysate sodium coming out of the patient to tailor the removal of sodium. And I'll also talk briefly about sodium profiling. So sodium profiling was introduced years ago to improve the intradialytic cardiovascular stability, to minimize complications and of high sodium dialysate that was given at some time to allow for better removal of fluid. And this variation during the hemodialysis happens with a variation of ultrafiltration rate and ultrafiltration profiling. And sodium profiling mainly there is an application phase where there is increasing in the conductivity and increase in the sodium concentration in the dialysate to allow for high ultrafiltration volume, then followed by a removal phase where the dialysate sodium is reduced so to normalize the sodium in the patients. And at some time during the last decade, there was loss of interest in sodium profiling because some studies or one single study found that it is associated with higher mortality, and some studies found that it is associated actually, although it aims at normalizing sodium, but actually sodium load is increased, and most patients have increased intradialytic weight gain on the sodium profiles. So in this article that says that it is a long forgotten issue, but it should be revisited, it says that there are decreasing profiles where we start with a high sodium to allow ultrafiltration, and then we reduce the sodium over the session. It is associated with cardiovascular ability, and it does allow for more ultrafiltration. But as we said, in the end, the patient usually, the part where there is low dialysate is not enough to remove the dialysate sodium, to remove the sodium excess that has been given to the patient in the first period. There's also alternating profile where there is periods of increased sodium with increased ultrafiltration, and then periods of decreased sodium with decreased ultrafiltration. And they found that it can be used in patients with disequilibrium, and especially in patients who are old in age, which because to give time for plasma refilling from the extra vascular space to the intravascular space. And there is less frequently used increasing profile where patients who have initial hypotension, so we don't remove volume initially, and as their hemodynamics improve, we can increase the rate of ultrafiltration. And as we said, the problem with sodium profiling was that sodium balance was often not calculated, but stepwise can effectively prevent intradialytic hypotension, and intradialytic hypotension alone is associated with mortality. Alternating profile is more effective in preventing disequilibrium syndrome, and to avoid this positive sodium balance that and increased because positive sodium balance is associated with increased intradialytic weight gain. We can aim for a sodium neutral or a sodium negative balance. This, if we combine sodium profiling with a sodium neutral or negative balance, this may eliminate this increased risk, and this may be more allowed if we integrate the biofeedback through conductivity monitor and real-time sodium sensors. Now, the concept of this is that you can, we said that conductivity monitors measure the sodium that's going into the machine. We can also measure the conductivity of the sodium that's or the dialysate that's being removed from the dialysis, and it's already integrated in some dialysis machines. And these microsensors that measure the conductivity and the sodium in the dialysate going in and the sodium of the dialysate going out, they are connected with the computer in the machine and the central processor unit in the machine, and can tailor the profiling so that we remove, maintain a neutral or a negative sodium balance, and do not load the patient at the same time, remove this, the correct amount of fluids. And trial with these new machines have found that the patient's sodium is maintained. So the difference between the pre and the post dialysis sodium in this automated sodium removal is actually maintained around the baseline sodium without leading to hyponatremia, relative hyponatremia to the patient, and without leading to sodium loading on the patient. Now, I'm going to refer to the Egyptian Society of Nephrology hemodialysis guidelines, which I find to be very interesting and very fruitful. And Dr. Hisham Said was one of the leader of this guideline. And the conclusion is going to be mainly to follow the guideline in this area. The guideline recommends that we maintain the dialysate sodium between 134 and 138, and it's preferably should be within 2 milliequivalent of the pre-dialysis sodium, so that we don't mobilize a lot of sodium, and we don't add sodium to the patient, and to stay sodium neutral as much as possible. Now, the dialysate solutions that are present in Egypt, the A component alone has 105 millimole, and when the B component is added, then it has 130 millimole, and we can adjust that. We can lower it or increase it on the machine. But also, to allow for maintenance, we should not only prescribe dialysate sodium, we have to take care of also the volume. The interdialytic weight gain should not exceed 4 to 4.5% of the dry body weight, and the ultrafiltration should not exceed 13 milliliter per kilogram per hour, to avoid the need for profiles and the occurrence of intradialytic hypotension. And this can often be achieved, the reduction of the interdialytic weight gain, by restricting dietary fluid and with it fluid intake, and also by reducing the dialysate sodium. So again, we should apply more accurate assessment of fluid and sodium status, especially in those patients who develop intradialytic hypotension or who develop disequilibrium syndrome. We should also always counsel the patient, always try to preserve residual kidney function, and may prescribe diuretics in patients who have still good urine output to reduce the interdialytic weight gain. And we should aim for adequate removal of excess salt and water. Maybe use sodium profiling very carefully, but it's maybe more safer in patients with volume overload that needs to be removed. Instead of increasing the dialysate sodium, to increase the time or the frequency of the dialysis to achieve adequate volume removal without the need for increasing the sodium load. So I'll talk next about the dialysate buffer. And during the interdialytic period, the 44 or 6 to 68 hours, depending on whether it's between 2 days or 3 days, there is decrease in the pH and decrease in serum bicarbonate as endogenous acid production occurs. And then during the 4 hours of dialysis itself does not remove the hydrogen that's present, the excess hydrogen that is present in the patient, but the dialysate includes bicarbonate and other alkali that can pass through the dialyzer into the patient, and they bind with the organic acids that's formed during the interdialytic period, correcting the acidosis and forming water that is removed by dialysis and carbon dioxide that is removed by the respiration of the patient. And usually a plateau is reached within 2 hours where there is normal blood pH and normal serum bicarbonate. The evolution of buffers is also interesting. In the beginning, they used bicarbonate, but it led to precipitation of calcium and magnesium carbonate, and it was associated with bacterial contamination. So in the 60s, they started using acetates. I experienced the last part of this period, and acetate was believed to be by the liver converted to bicarbonate. It had bacteriostatic effect and it was low cost, but it was associated with cardiovascular instability, and in patients, especially with liver disease, it accumulated, causing nausea, headache, and fatigue. So in the 1980s, it was abandoned, and we all now use bicarbonate again to either in the form of bags or in the form of capsules as the main buffer, but also the component A includes small amounts of acetate, small amount of lactate or citrate in the acid compartment that is still removed, converted in the body to bicarbonate. So we have bicarbonate from the compartment A or the B compartment, as well as from the A compartment. And as we know here, the bicarbonate, after it's diluted, it's usually 33 to 32 mole. And the acetate gives additional 2 mole. So that comes to about bicarbonate dose of 35 millimole. However, the base requirement varies from patient to patient according to protein intake, as protein is the main acid producing component in diet. The fixed acid production, the metabolism of the patient. So patients with more activity, patients who are in sepsis, they will have more acid production, the volume of bicarbonate distribution, and the ultrafiltration rate, because a part of the bicarbonate is also removed by the filtration. And dialysate bicarbonate actually should also be individualized. Actually, raising the bicarbonate is very controversial because rapid increase in pH with and serum bicarbonate by dialysis, it leads to formation of too much carbon dioxide, and it may lead to hypercapnia. This correction of pH, if it's too rapid, it leads to electrolyte imbalance. Mainly, it leads to shift of potassium intracellular and vascular calcification. The shift of potassium and the hypokalemia may lead to arrhythmia and hemodynamic instability, and also it may lead to immune system deficiency. So actually increasing the serum, the dialysate bicarb is associated with complications. Also, overcorrection of acidosis leads to reduced ionized calcium and interfering with myocardial contraction. It may increase tissue calcification, may shift potassium to the intracellular, leading to hypokalemia and cardiac arrhythmia. It increases the affinity of hemoglobin for oxygen, leading to tissue hypoxemia, while undercorrection of acidosis during dialysis leads to increased mortality, increased catabolism and abnormal protein metabolism and malnutrition, and aggravates osteodystrophy. So it is often not measured, but we should actually target a bicarbonate pre-dialysis of 24 milliequivalent per liter and a post-dialysis bicarbonate of 28 milliequivalent per liter. But I think most of us do not measure bicarbonate or serum bicarbonate in patients on dialysis. Why this level? And it's also recommended by the Egyptian guidelines, because theoretically, if we have a post-dialysis plasma bicarbonate of 28 with a distribution of in 40% of the body weight, and the patient takes an average protein, which is recommended of 1 gram per kilogram per day over the 44 hours of the interdialytic period, there will be 4 millimole bicarbonate use, and the patient pre-dialysis will have 24 millimole bicarbonate plasma concentration. So this is the ideal situation. But again, if we measure the plasma bicarbonate in most of our patients, we'll find that they are far from this target. And there are a lot of factors, as we said, that affect the acid-base balance, both in the dialysis, the dialysate bicarbonate, the blood and dialysate flow, the type, the ultrafiltration grade, the rate, the bicarbonate gradient, the residual renal function, the diet, and the bicarbonate distribution space. But we should tailor the dialysate buffer. We should measure pre and post dialysate bicarbonate and avoid a high bicarbonate in the dialysate, because high bicarbonate in the dialysate is associated with increased mortality regardless of the post-dialysis bicarbonate. So even if the patient is acidotic, we should not correct the acidosis by increasing the dialysate bicarbonate. As we said, that rapid correction of the acidosis leads to complications. And if the patient has persistent pre-dialysis acidosis, we can attack that by prescribing interdialytic oral bicarbonate, by increasing the dialysis dose, whether the frequency or the duration of the dialysis, and by giving the patient nutritional advice to reduce animal proteins especially, and to increase fruits and vegetables in his diet. On the other hand, if we have a patient with pre-dialysis bicarbonate of more than 27 and he is alkalotic, we should exclude causes of acute metabolic alkalosis like excessive alkali administration as an antacid, for example, vomiting, nasogastric drainage, or if the patient has high volume ileostomy drainage, or also severe malnutrition can lead to this. And in these patients, actually, we may reduce the dialysate buffer to achieve better pH in the patient. Next, I will be talking about dialysate potassium. And dialysate potassium, because of the intermittent nature of dialysis, it undergoes removal both by diffusion and convection, and it undergoes large fluctuations. And the rate of decline depends on the gradient between plasma. So a patient starting with a potassium of 7 will have more rapid decline in his potassium than a patient with 5.5 starting potassium. And the largest shift is during the first hour. And that's why also sometimes the largest incidence of arrhythmias and complications may be during the first hour of dialysis. However, although we reduce potassium quickly during the dialysis, usually after dialysis, there is a large rebound in the potassium. And this rebound, both this reduction and this rebound and these rapid shifts may trigger arrhythmia. And part of this rebound is because we remove only potassium from the extracellular compartment, while 98% of the potassium is intracellular. And the shift between the extracellular and the intracellular is affected by many factors, including acid-base balance, which is corrected again in the first 2 hours of dialysis rapidly. So part of the potassium that was extracellular and that needed to be removed has been moved intracellularly. Plasma osmolarity, by glucose and insulin, by catecholamine activity, and by drugs, like for example, if the patient is taking beta agonists or beta blockers. So extracellular potassium concentration may play a role in hyperkalemia and hypokalemia and lead to arrhythmia and sudden death. The shift between the intracellular potassium and the extracellular potassium is affected by multiple factors. So again, the intracellular potassium may be depleted in the presence of hyperkalemia or hypokalemia because of the presence of acidosis and other factors. And the presence of high dialysate serum potassium gradient also leads to rapid change in the potassium, leading to arrhythmia and sudden cardiac death. And this arrhythmogenic effect of potassium is increased by higher pre-dialysis potassium, by the rapid correction of metabolic acidosis, and by the use of low dialysate calcium, as well as high ultrafiltration rate. So actually, we should aim to maintain the extracellular potassium level at a reasonable level by first correcting acidosis, also by reducing dietary potassium. In patients where dietary potassium does not reduce it, we may prescribe potassium binders, either the older sodium or calcium polystyrene or the newer potassium binders. and reducing potassium will improve the blood pressure. And in patients with high potassium or hyperkalemia, to reduce the dialysate serum potassium gradient, we may use lower dialysate potassium concentration. And dialysate potassium in Egypt, we cannot modify it, but higher dialysate potassium was associated with significantly increased mortality, but it may be prescribed with patients with potassium where the serum potassium is over 5. Fixed dialysate potassium will lead to rapid fall in potassium if the patient has high potassium in the blood because of the gradient, and it also associated with high incidence of arrhythmia. Low dialysate potassium, again, is safe in patients with low potassium, but in patients with higher potassium, it can lead to a rapid shift in potassium. Again, in Egypt, we only have a concentration of 2 millimole in the both dialysate concentrates, but actually it's better to tailor the potassium prescription. And in this article, they set ideal dialysate potassium for each pre-dialysis potassium. But again, this is not something that we can apply. Another thing that is being explored to prevent rapid shifts in potassium and the associated arrhythmias with it is potassium profiling that was introduced by Orsino and Donati, and it mainly gradually decreases dialysate potassium to allow smooth potassium removal, and it measures potassium continuously to maintain a gradient between the plasma and the potassium by 1.5 milliequivalent, and they found that it is effective in reducing intradialytic premature ventricular contractions. Again, when we go back to the guidelines recommend avoiding potassium less than 2 and more than 3 millimole. The potassium we have is 2 millimole, so it's between this, and they recommend also that we do frequent serum potassium monitoring. And again, when you look at how we should apply this and how we should personalize potassium management, we should monitor pre-dialysis potassium levels, and the lowest mortality was found that in patients with pre-dialysis potassium between 4.6 and 5.3. So we should maintain pre-dialysis potassium within 5 milliequivalent, and it should not exceed 6 milliequivalent. In the patients with high pre-dialysis potassium, because we cannot modify dialysate potassium, we may consider dietary advice, giving potassium binders, reviewing medications and reducing medications that increase potassium, and we should also consider increasing dialysis frequency. In patients with low pre-dialysis potassium, they are mainly patients who are malnourished. Again, we should give a dietary advice, and they found that patients with low pre-dialysis potassium improve with moderate and incremental muscle exercises even during dialysis. When we move on to dialysate calcium, the calcium, again, there is the slowly exchangeable calcium pool. There is the rapidly exchangeable calcium pool in the blood. And then there is the ionized calcium, which is mainly the part that is affected by dialysis. And the maintenance of the calcium balance is mainly through the activity of the bone exchangeable pool, which in patients with dialysis is affected by vitamin D, by PTH, by the age, and by the pH also. Dialysate calcium and ultrafiltration volume can remove some calcium, and the concentration of the ionized calcium that is present in the blood, which also related to the pH of the patient. And again, there was evolution in the calcium along the years. In the start, because of the frequency of hypocalcemia in patients with end stage, they started with a calcium of 2.5 milliequivalent, and because of the hypocalcemia with dialysis, they increased in the 1970s to the 1990s. But then as they started giving vitamin D agonists and calcium-based binders, and patients started to develop hypercalcemia. The KDOQI in 2003 recommended reducing the dialysate calcium to 2.5 milliequivalent, but with the advent of non-calcium binders and calcimimetics, there was no need to reduce the dialysate calcium, and they said that the KDIGO in 2009 recommended dialysate calcium between 2.5 and 3. But as we use the non-calcium binders and calcimimetics, we don't know how it will progress in the future. The Egyptian Society of Nephrology guidelines state that the dialysate calcium should be maintained at 1.25 to 1.5 millimole. This corresponds to the latest KDIGO guidelines of 2.5 to 3 milliequivalent. But unfortunately, some of the solutions, so the red solution, it has the 1.5 millimole, which is the higher end of the calcium, while the green solution contains actually calcium that is higher than that recommended by the guidelines. So actually we have high dialysate calcium, and manipulation of the dialysate calcium can effectively change serum calcium phosphate and PTH. It can change bone histology, and it can affect the cardiovascular disease either by causing arrhythmia if the ionized calcium is changed rapidly by dialysis, and by causing vascular calcification on the long run. So high calcium dialysate leads to positive calcium balance and puts the patients at increased risk for hypercalcemia. This will be associated with vascular calcification, increased risk of cardiovascular disease, sometimes sudden cardiac death if we raise the calcium quickly, and it leads to suppression of the parathyroid hormones and leads to adynamic bone disease, while low calcium dialysate leads to negative calcium balance and hypocalcemia, and this will lead to secondary hyperparathyroidism and promote more vascular calcification and bone demineralization. Also, the low calcium may lead to QT interval prolongation, myocardial ischemia, and cause hypotension. So should we aim for a net zero balance? And again, net zero balance in some patients is associated with hyperdynamic bone disease and vascular calcification. So actually there is no formula that is suitable for every patient. Now, we do ask for lower dialysate calcium, but we should monitor the calcium, phosphorus, and PTH of patients on them. It does the slow progression, and it improves biopsy-proven bone turnover. In Egypt, it may also have a role because of the price, the high price of the non-calcium containing phosphate binders and the calcimimetics. Using lower dialysate calcium may allow us to give calcium containing phosphate binders and to continue to use calcitriol to suppress the parathyroid hormones instead of the calcimimetics. But again, in patients of dialysis, we are always in limbo between two aspects of the bone turnover: the high turnover, where the patient has low calcium, high phosphate, high PTH, high alkaline phosphatase, and the low turnover, where the patient has high calcium, low PTH, and low alkaline phosphatase. And low dialysate calcium and sometimes also negative or zero calcium balance increases parathyroid hormone and pushes the patients more towards the high turnover, while if we persistently use high dialysate calcium, like giving calcium, calcitriol, and aluminum, it may push the patient into the low turnover. While our aim is to keep the patient in the middle of this spectrum with calcium that is close to normal, phosphate that is close to normal, PTH that is between 150 to 300 millimole, and to keep healthy bones. So again, we should tailor calcium prescription, and we should monitor calcium, phosphate, and PTH. And maybe among the electrolytes we mentioned, this is the most frequently monitored set of electrolytes in these patients. And we should not only look for dialysate calcium to correct CKD, MBD, but we should use all available modalities, including calcium containing, non-calcium containing phosphate binders, calcimimetics, and calcitriol appropriately. And we should manage trends rather than absolute values to try to always keep the patient between the hyperdynamic and the adynamic bone disease. Dialysate calcium should be probably around the 1.25 millimole. So we should ask again the companies to reduce the 1.75 millimole in some concentrates. In patients with hypercalcemia, before using low dialysate calcium, we should exclude excessive calcium intake, high doses of vitamin D, and switch these patients to non-calcium containing phosphate binders and calcium mimetics. In patients with secondary hyperparathyroidism and hypocalcemia, we can give higher doses of calcitriol and calcium rather than prescribing high dialysate calcium, again, to maintain the calcium and not elevated or corrected during the session. And in patients with hemodynamics instability, because lower calcium can also lead to to increased intradialytic hypotension, we should opt for more high dialysate calcium. In adynamic bone disease with low PTH, we may use low dialysate calcium to improve PTH and bone morphology. In hyperbiodynamic bone disease, we should use relatively higher dialysate calcium, but avoid oversuppression of the parathyroid hormone. And actually, in long daily or nocturnal hemodialysis sessions, low dialysate calcium would leads to excessive bone mineral loss, and also it leads to loss of phosphate. And in these patients, they need either calcium support or relatively high dialysate calcium, and sometimes they also need higher or they add phosphate to the dialysate to improve the loss, to account for the loss of phosphate during the long hours. And CKD, MBD, and the maintenance of the calcium and the bone disease, bone health in bones is actually very complicated. And this very recent article has proposed that we use clinical decision support system through artificial intelligence by examining multiple patients and their trends, and to choose in each patient which manipulation to give, whether to give calcium containing, non-calcium containing, increased dialysate calcium, reduced dialysate calcium, based on and algorithms based on artificial intelligence. Because again, in many patients, we are faced with a dilemma: when we correct one thing, the other thing fails. So again, maybe in the future, we will have more tools to effectively treat these patients. Move on to dialysate magnesium. Magnesium is a cofactor in more than 300 human enzymatic reactions, and hypomagnesemia is associated with cardiovascular mortality, vascular aging, leg cramps, and hypokalemia. So, and also plasma magnesium may play a very important role in PTH and in calcification, and it may have a lot of ramifications in CKD, MBD. And again, I think that most of us do not measure magnesium routinely in our patients. And this article by Sakaguchi et al. In 2014, it reviewed the mortality in relation to the serum magnesium, and it found that low magnesium is associated with increased mortality, and high magnesium is associated with increased mortality. And maintaining the magnesium from 1.8 to 2.8 is actually associated with the best survival in patients on dialysis. Along with this article, there was a commentary by Kurivode and Davenport that stated that the increase in mortality with hypomagnesemia may be related to the increase in blood pressure, increase in heart arrhythmia, in increased calcification, and increased serum PTH, in increase in having a prothrombotic type, in having a pro-atherosclerotic phenotype with increased oxidative stress and inflammation, while hypermagnesemia was mainly associated with mortality if it was associated with high PTH, maybe again because it was associated with increased vascular calcification. And again, it may be safe to or safest to keep the patient between 1.8 and 2.8 milligram per deciliter. But again, is it agent provocateur or innocent bystander? They note that patients with the lowest serum magnesium are older, have more comorbidities, They are associated with lower pre-dialysis urea, lower pre-dialysis albumin and phosphate. So it may be actually a marker of poor nutritional state, but it definitely has a role in the mortality and all-cause and cardiac mortality in dialysis patient. Dialysate magnesium, does it have a role in correcting this magnesium? It's a major determinant of magnesium balance in dialysis patient. It can cross the hemodialysis membrane easily, and only a dialysate of lower than 0.5 millimole will result in diffusive elimination of magnesium. And when they used magnesium-free dialysate, it was poorly tolerated because of leg cramps, and the dialysate we have usually has 0.5 millimole. But studies with increasing dialysate magnesium, it showed that to reduce vascular calcification showed inconsistent data. Some studies found improvement in calcification, some studies didn't find improvement in calcifications. So maybe, again, to avoid the rapid shift in electrolytes, we should look at other factors affecting magnesium, like magnesium food intake. Magnesium is commonly low in poor nutrition. In drugs, PPIs are commonly prescribed to dialysis patients, and they are associated with hypomagnesemia, while other drugs may cause magnesium load, like antacids containing magnesium phosphate binders and some laxative. So we may, in patients with magnesium that is above or below the ideal level, check their drug concentration. Again, the guidelines, the Egyptian guidelines, they recommend a prescription of 0.5 millimole, and particularly in hypokalemic patients. And this is already the magnesium that is present in both concentrates that are available. And again, to tailor magnesium management, we should measure magnesium, maintain it closer to 2.5 milligram per deciliter. In patients in hypomagnesemia, in the absence of higher magnesium dialysate, we should improve nutrition, avoid proton pump inhibitors. Magnesium is present in nuts and legumes and avocados and spinach and in bananas. So it's foods that actually our patients avoid. Lastly, I'll be talking about dialysate glucose. And again, at the advent of dialysis, they used glucose actually before TMP for osmotic to create osmotic pressure for ultrafiltration. But of course, as machines developed and transmembrane pressure became the force behind ultrafiltration, dialysate glucose drastically was reduced. And glucose-free dialysate, which is used in Egypt, it avoids hypertriglyceridemia, avoids increasing bacterial growth in the dialysate, but hypoglycemia and avoids hyperglycemia. But hypoglycemia can occur in diabetics on insulin and sulfonylurea, and glucose-free dialysate may cause greater loss of amino acids in dialysate. Some countries or some centers use isoglycemic 100 milligram per deciliter dialysate, and some use moderately hyperglycemic dialysate with glucose of 200 milligram, but it's associated with hyperglycemia. It is pro-inflammatory, leads to insulin-resistant anemia, fatigue, and anorexia. So if we are going to use glucose dialysate as the guidelines, the Egyptian guidelines recommend, it should be around 100 milligram to be isoglycemics, and it should not be used during hemodiafiltrations because it will be supplied to the patient. So I will conclude, and I think that there are a lot of gaps in knowledge, and there are a lot of questions that, especially in the sodium balance and the sodium dialysate. And as we saw that there was an evolution over the years, and maybe in the years to come, there will be change in the recommendations in the dialysate composition. There is also advances in using the dialysate as a vehicle, and there was ferric pyrophosphate and iron supplement that can be added to the dialysate to improve the dialysis in patient. Newer dialysis protocols pose different problems. As we said, in long nocturnal dialysis, which lasts 8 to 10 hours daily, it does facilitate sodium removal, but it can lead to sodium loss, and it can lead to loss of other electrolytes, like there is increased risk of hypokalemia, and there is increased risk of hypophosphatemia, leading to them adding phosphate to the dialysate. So in sodium, we should individualize dialysate sodium, keep it around the plasma sodium, and always think of the ultrafiltration and try to maintain the patient at dry weight without intradialytic hypotension and without intradialytic weight gain, and maybe reduce dialysate sodium below, but close to the serum sodium in patients with positive balance. For bicarbonate, we should more frequently monitor pre and post dialysis bicarbonate, and we should keep it at around 24 pre and 28 post. And we should avoid high dialysate base concentration, even in patients who are acidotic because of its complications. Potassium, again, we should ideally maintain a pre-dialysis potassium of around 5 milli equivalent, and we should, because we cannot adjust dialysate potassium, again, if the patient has hypokalemia or hyperkalemia, look at drugs, phosphate potassium binders, and diet to improve potassium. Calcium, again, there should be lower calcium than the calcium that is present in some of our dialysate composition now. But again, we should not look at dialysate calcium alone to correct the CKD MBD that's present in patients, and we should use all the methods that are available to us to correct the calcium and the CKD MBD present in patients. Magnesium, again, dialysate magnesium cannot be changed, but we should examine the magnesium level in our patients and keep it at the recommended levels through diet and through supplements maybe, and by reducing drugs like PPIs that reduce magnesium. Glucose isoglycemic dialysate may be an option in patients with malnutrition and in patients with hypoglycemia during dialysis, but it's not available. And I know that next week, Professor Mohammed Kamal will talk about dialysate adequacy, and maybe we should look at dialysis adequacy differently. We should look at the patient as a whole, aim for integrated and personalized approach, not only look for the KT over V and the dialysis adequacy, but look at the nutritional status of the patient, at the quality of life of the patient, at maintaining the residual function, as well as frequent monitoring of the volume and electrolytes of patients, and not only look for dialysis to improve the patient, but also look at nutrition, at the drugs the patient is taking, as well as the activity of the patient and the maintaining exercise and maintaining activity to maintain the health of the patient. Thank you very much, and sorry for being too long. Thank you.
Thank you very much, Professor Dr. Yasmine. As expected, the apple falls below its tree. So I really enjoyed that, and I'm pleased that you give us the summary of our publication of our guidelines. So we are using these guidelines. And if you allow me to open the discussion and some comments, is that you really enriched our information about a lot of information from all the ions, water, sodium, potassium, and etc. So I just hide that dialysate should be considered as a drug, and a drug should be given in the right way, in the right dose, to the right patient at the right time, and finally at the right composition. So if we apply that a dialysate is a drug, we can have the impact on the patient by individualizing. We are missing individualization of such. You also mentioned perfectly that glucose in concentrate is preferably, yes, it's preferably and available in Egypt, but you have to request that directly from the producer. I use it so much, but you have to ask about that. It's available for production. One of the questions that I usually ask myself, can we add something to the dialysate to be as a medication, like there's a trial of giving iron-containing dialysate. I will give my opinion, then I will give your microphone for you. I doubt on that because the right drug should be given to the right patient at the right dose. While if you have a dialysate containing iron, for example, and are using low flux, it differs from high flux and from high flux to super flux, because simply back filtration of the dialysate will contain more and more of the developed and dissolved medication in that. So you know that up to 6 to 8 liters are infused in the patient in high flux dialysis. So what's your opinion about a drug modified dialysate?
Well, I think, as you said, it's very correct. We cannot, even when we give IV iron, we do not, we tailor it to the patient, and we cannot, again, mass produce different concentrations. And again, why limit the addition or the giving of a drug, any drug, during the dialysis session alone? So I don't agree that it is very effective, and I don't think it's going to be very successful, because again, you have to tailor the dose of the drug. Actually, even the constituents of the dialysate, the other constituents, they should be tailored, and we should have multiple concentrations that are prescribed to different patients. For example, different potassium levels in patients with different potassium, serum potassium. But to individualize this, we have to think also of the logistics and the prescription. I don't know if at one time there will be attached to every dialysis unit, a unit like the clinical pharmacy units that prepares infusions, that where we can tailor or individualize dialysate composition on site for every patient. Maybe this can be done in the future, but again, when we are doing mass production, we cannot tailor the dose, and with every drug, we have to tailor the dose.
So what's your opinion, Professor Yasser?
Professor, I think the pharmacokinetics will be too much different, and yes, the dose, and we cannot guarantee the dose here, and we cannot work with the usual doses we are familiar with regarding iron, for example. We will have very different pharmacokinetic level, very different clearance level, and it needs many large studies to adjust the doses for such a portal of entry and portal of intake of drugs in such a case.
Yes, so I raise this point because it's very important to have that in mind. Not every research is applicable or safe to the patient, so you have to be fully aware about that.
It's very interesting. Very interesting to have very documented results for such a route of administration.
Yes, you cannot control the dose, so you cannot control anything about the toxicity, especially with drugs that have good toxicity. And sometimes they're giving a literature about dialysis membrane with vitamin E as an antioxidant. That's very, as well, is not effective, because you can give it by tablets and you can control the vitamin level. Going to the second point, I think we have to add the pyrogenicity and the bacterial content in the dialysate. I understand that the canister of concentrate has no bacteria because it's very osmotic, but on retained canister after opening, you can have pyrogen from dead bacteria, and even you have DNA fragments from bacteria that can pass into toxin filter. So do you agree that, Professor Yasmine, that we have to move or shift to single session canister of 5 liters? Because I can't guarantee the 20 liters to have bacteria inside, raising the endotoxin and bacterial DNA.
Of course, and I don't think that we monitor even the bacterial contamination enough. We don't, and again, it's left open, and maybe use of capsules has reduced the fear of contamination from the diluted bags of bicarbonate, but still the canisters remain a source, and they may stay beside the patient or beside the machine overnight, and especially in glucose-containing canisters, it will be a problem that should be monitored. Yeah. And again, as we use hemodiafiltration in some patients, this may be a bigger problem in patients who are on hemodiafiltration.
Yes, exactly.
Once per month monitoring for bacterial content and bacterial analysis of the dialysate solutions is not enough. We need more and more monitoring for this issue.
Yeah, you have to measure the endotoxin and you have to measure the DNA fragment, but clinically, we have to move to single session canister, closed canister, and discard it immediately after the session. It's 5 liters. So this is we have to proceed for that way, not for the 20 liters. I know that 20 liters is cheaper, but carry a risk of inflammation and as well. Coming to, I think we have a lot of professors here. We have Professor Said Khamis.
Professor Said Khamis.
And I will raise a point, and we will need a comment from one of the Greek experts in this field. I memorized 1 decade ago from USA a catastrophe of respiratory arrest and sudden death due to formula of granules using in bicarbonate and make alkalosis. It was a very famous company, but unfortunately catastrophic. So Professor Dr. Said, welcome on board, and would you please tell us how we can proceed with alkalosis and how we can prevent that alkalosis besides the serum bicarbonate concentration measurement, because it's not applied. We cannot measure serum bicarbonate to all patients.
Good evening, Professor Yasser, Professor Yasmine, and thank you for this elegant presentation. Actually, it is Professor Yasmine covered almost all the items in this tough and challenging issue. But in the meantime, you asked about the bicarb, or in another meaning, the alkalosis in our patients. Also, this is a challenging problem. I remember 2 case reports, for example, by the way of this alkalosis in the patient with COPD or obstructive pulmonary disease or end-stage disease. I mean, they develop usually chest pain by the end of, near the end of dialysis, and the treatment at that moment was just to hold dialysis low for a while, for 15 minutes, for example, and then resume dialysis again till the end of dialysis. For sure, after ruling out the AMI and I mean acute coronary syndromes. I know that this issue is, as I said to you, it's a very challenging. How to adjust, how to measure this bicarb. Should we measure bicarb more frequently, as you said, and the Professor and Yasmine said? It should be. But another, and I wanted to answer your question by another question, if you allow me.
Yes, sure.
Why in our country we have only 1 or 2, I think only 1 fixed formula, and maybe me and you and almost all of our colleagues, we discussed this issue many times, and we said, oh, we shall contact the manufacturers, maybe we shall change this issue later on, and maybe almost now 10 years, no change. Absolutely.
In bicarbonate, you mean?
No, I mean generally, we should have different formulas regarding potassium, calcium, bicarbonate.
Yes, we have. Yes, we have, but we have to ask. If you are not aware of the importance of the dialysate, you will not ask. But if you know that and you start to individualize, you can ask low calcium, for example, but we don't have a higher potassium above 2.
We don't have, we don't have.
Yes, and fixed magnesium.
Yeah. Second question, Professor Hisham, I remember you advised glucose containing what's called dialysate, 100 milligram as per the guidelines, and you strongly recommend, if you remember, in the COVID era, you said it's and you said it's available. And my question, it affects also the adequacy of dialysis by a way or another, or not?
Yes, it's an intelligent question. And I am always thinking about that, and a clinical study is running right now on the adequacy of dialysis in patients either with glucose containing or not, and in patients with low dialytic temperature and regular dialytic temperature. Theoretically, it will affect, but to a very minimal, non-touchable, especially for the small solids, because we recommend that 100 millimole that is usually equivalent to the plasma glucose. So finally, the tangential increase is minimum, not the urge to use the glucose for that area.
Yeah. Okay, thank you, Professor. Thank you.
Thank you very much. And we have here one of the great professors from Alexandria as well, Professor Dr. Ayam Al-Aggan. We are just thank you for your accompanying our webinar today. I will highlight one point and read your comment, if you please. Yasmine perfectly said that the plasma refilling, this is a very important issue because it differs from patient to patient. The plasma refilling starts at least 30 minutes after starting of dialysis. So we have to make ultrafiltration quite low at the first 30 minutes because plasma refilling compensating after 30 minutes of dialysis, not before. Secondly, in most cases, it is not increased than from 400 to 600 per hour. That's why patients may have hypotension if you go up with ultrafiltration. Third one is the hypoalbuminemia. It definitely affects the plasma refilling. So I need to hear from Professor Dr. Ham, if available, that what's your opinion and the perfect clinical experiences in the plasma refilling?
I don't think Professor Hayem is
not available. Okay, we have Professor Manel Deep, Professor Manel. Okay, so we can hear from you.
Okay, I think there are some trials about giving albumin in patients who are hypoalbuminemic during dialysis to improve the fluid removal. But again, it is recommended in the guidelines, in the Egyptian as well as the other guidelines, that we should not raise the rate of ultrafiltration, or it's not best to prescribe a rate of ultrafiltration that is more than 10 to 13 milliliter per kilogram per hour. And if we have a 60 kilogram patient, then 600 milliliter per hour because of this plasma refill time. And in patients with intradialytic hypotension, maybe we should increase the period to reduce the ultrafiltration rate per hour and allow for the adequate removal of the time to allow for plasma refill.
From my opinion, I need to move from the kg to the surface area in all. For example, if you are going to KT over V, no, we need to move to surface area. And even if you are using the ultrafiltration, we have to move from per kg to per surface area. It's better. Going to questions.
You have questions in the chat, Professor
There
Hisham?
are questions in the chat.
Yes, yes. Professor,
yes, from Rami Abu Bakr. How to thank you for great presentations. How to avoid rapid correction of symptomatic hyponatremia in hemodialysis patient, especially in hypervolemic patient.
Okay.
And in clinical life, what's your recommendation about lab frequency of monitoring all electrolytes you mentioned? And this really was my question. I want to ask you.
Okay, for the first question, there was a slide that I removed from the presentation. About,
I think it was the most important slide.
There was a slide actually in a very interesting article that talked about potassium and sodium disorders in hemodialysis patients. It's the same article I got from the tailored potassium prescription. And actually in acute hyponatremia, it recommends that we use a dialysate with usual sodium, that because we need to rapidly correct the sodium to avoid the cerebral edema. And in patients with chronic hyponatremia, chronic symptomatic hyponatremia, that we should actually lower the dialysate sodium as much as possible, and the lowest is 130 milli equivalent per liter, and we should utilize short sessions with low blood flow to allow for gradual removal of the sodium and not develop and not lead to pontine demyelination in patients with chronic severe hyponatremia.
Yeah, it's a very difficult answer. I believe that it's a very difficult. Yes, I memorized that 1 year ago. Was in debate with Professor Cano. It's not a debate; it's a discussion with Professor Cano physically when we're in the hemodialysis conference. If you have hyponatremia during hemodialysis or pre-dialysis, you have two factors. I mean chronic hyponatremia, which is 2 days apart from the development of hyponatremia. It could be due to water intoxication or volume, dilutional factor, or other factors. So if you are going to do dialysis in such way, you should not exceed the conductivity or sodium above 10 millimole above the patient. So if you have a patient with, for example, 110 or 115, you should not go more than 10 millimole, and monitor closely the intradialytic potassium, serum potassium after ultrafiltration. So I believe that this point is very critical for decision.
Let me explain. I think that Rami question, because this is usual, but this is also my question. You mentioned in every item of your talk, Professor Yasmine, according to pre-dialysis level, adjust your level of this molecule according to pre-dialysis level. So I got the idea that we should monitor our patient pre-session regarding his electrolyte panel or his electrolyte profile. Do you recommend this really, and how frequency? What's the frequency of measurement do you recommend for this electrolyte panel of our patients? How much should we measure this electrolyte panel?
Oh, I did not find any recommendations, but I think that we again should tailor the monitoring again in patients with frequent intradialytic hypotension, in patients with
symptomatic patient in general.
You should measure it more frequently.
Yes, an asymptomatic patient.
But at least in other patients who are stable on dialysis, maybe every 3 months. Again, we only look at the calcium and the phosphorus and the PTH, but we should be, this is something that is new to me, but it's something that we all underutilize. But I think in patients with more symptoms, you should do it more frequently.
More frequent, yes.
In stable patients, you should do it at least maybe every 3 months.
3 months? Is it a long period?
No, it's
I think
monthly would be too much.
I think it should be very closely monitoring in symptomatic patients and at least once monthly in patient stable on dialysis without complications. I can see Professor Said Khamis raising his hand.
I want to interfere here.
Regarding how frequent to monitor this electrolyte, it is a big dilemma, as you said, and Professor Yasmine said. Usually we measure in most of our centers monthly, as you know. But even surprisingly, it is a large study done, maybe published in JASN last year. They said as a cost-effective, every 1.5 months equal to 1 month. I mean, the same outcome. So why not to measure every 45 days rather than every 30 days? So long time.
Yes, exactly. You can measure it once monthly in asymptomatic clinically stable dialysis.
1 month, even maybe 1.5 months. But as Dr. Yasmine said, if there is a special situation, we should monitor more frequently. The problem, as you know, Professor Hisham, sorry to say, it's not a criticism, but actually it's a concern. In most of our centers, we do this monthly lab, and unfortunately, no one look at these monthly lab results, and no one will take action plan regarding these results. Despite you put the guidelines, you do everything that needs this action plan to be done, but unfortunately, no one look at these monthly lab results and take an action plan based on these monthly lab results. What's your opinion?
Be optimistic, Professor Said. We put this tone in the guidelines, and I think from the couple of years ago that there is a great awareness by the webinars, CME, guidelines, reading. Yes, it's awareness. Guideline is not a constitution, but it's a guide. And the country's health service provider are measured by how much they are applying the guidelines. And so if you look back to the guidelines, I put the guidelines, then I put the clinical performance monitoring. So later years, we'll check the dialysis centers, how much of the guidelines, current guidelines is applied, and then you have a score for your center. And we can catch the achievement and action plan for improvement. These are steps. So we have to put guidelines, then to follow and monitoring application of guidelines, and finally to give a score.
I do agree with you, Professor Hisham. And I think one of the solutions is to make random auditing to see is it this implementation issues or not, to follow this critical issue.
It is not to be applied except if you are varying the reimbursement according to your achievement. Yeah. If you put, for example, that this center is the 5-star center, so the reimbursement for the dialysis session is X, and if you are getting 3 stars from applying, you can have X minus 20 or 30%. So this is a current, yes, it should be like that.
Yes.
For improvement.
Yes, sir.
We have 2 questions on the chat on the same topic from Professor Manal Deeb and Dr. Abdu Mansi about the dialysis in hypokalemic patient. In severely hypokalemic patient, what are your recommendations? And about the adding of the potassium in the dialysate in severe hypokalemic patient during dialysis.
Again, there was recommendations. I want to share it again. This slide, there was a recommendation to tailor the potassium based on each patient. But again, I don't think that the dialysate potassium will correct it, so that actually in patients with pre-dialysis potassium of less than 4.5, the dialysate potassium should be 4. But again, adding to the dialysate, the 20 liters of dialysate, it will be very difficult to be done on site in the dialysis sessions. And maybe it will be preferable to give the patient IV infusion instead of adding it to the dialysate. I don't think what Dr. Hisham thinks about this.
Yes, we used to see such patients with hypokalemia and need to do dialysis. And we have 2 options here. In general, the dialysis station removes around 70 to 80 millimole, a maximum by 100 millimole of potassium per session, meaning that you need to compensate for the loss. But if you have a hypokalemia, the movement of potassium is lower, so we expect the removal of potassium is less than in patients with hyperkalemia, according to the diffusion gap in between. To my opinion, and in my clinical experiences, we use either. If you have the patient stable and have a central line, we are giving a potassium during the hemodialysis session in the form of 10 to 20 millimole per hour, and to compensate for the potassium loss. And if the patient has no vascular access central line, we can modify manually, again, it's manually, compensate for that by putting potassium chloride according to the calculation how much you need potassium in the concentrate. So we used both procedures years ago, and I think it works well. But you have to do dialysis. You have to do dialysis. There is no contraindication.
Which
What
one
is
do you prefer, Professor Hisham?
And Professor Yasmine regarding the role of 7 to detract 7 minus the serum potassium to be the dialysate potassium concentration. Is it applicable or valid, this rule?
I think again in literature they differentiate between acute hemodialysis and chronic hemodialysis. So in defects in acute hemodialysis patients, they need more rapid correction, while in patients with on chronic hemodialysis, you can maybe use it and slowly over several sessions remove the potassium load.
Yeah.
Which method do you prefer, Professor Hisham, from the two methods you mentioned earlier regarding?
It depends. It depends. If the patient has a serum potassium below 3, meaning that the total potassium loss in the body is above 200 millimole, because 1 millimole drop in serum potassium may be more than 100 millimole loss of the total body potassium. Subsequently, if the potassium is below 3, we have to infuse the patients at a rate between 10 to 20 millimole per hour in the central line. But if the potassium is critically borderline, like example 3.5, and you are afraid of more drop during dialysis, we can increase the potassium from 2 millimole to 3 millimole according to the volume of the dialysate you can use.
Okay, clear. We have no more comments and no more chat.
There was a question about the component of dialysate in cases of dialysis due to hypercalcemia. So I want to listen to the advice of Dr. Hisham Sayed in this. I think there will be enough in patients with hypercalcemia. There will be enough gradient between the serum and the dialysate to lead to calcium removal. But again, if a patient is hypocalcemic and severely, can we add calcium to the dialysate like you mentioned in the hypokalemia?
Hypocalcemia and hypercalcemia should not be managed absolutely by dialysis, because we have other points to modify rather than a dialysis. So put the dialysis as the last step. If you are having hypocalcemia, you have to increase the oral calcium, not to increase the dialysate calcium to 1.75, because it suppresses more the PTH as you perfectly described, and make the possibility of intravascular calcification and etc. But if you have a hypercalcemia, this is a problem, because hypocalcemia can increase oral calcium, vitamin D, according to the mineral point Z. What's the case of hypercalcemia? We are using 1.25 and usually fails to drop the calcium to the safe level. I mean that if you are using calcium above 13, for example, with the hyperviscosity syndrome, we use the 1.25 as a general principle, looking for the hemodynamic instability, because we can induce hemodynamic instability. And if not improved within a week of our procedure, we go to other medications that lower the calcium, and very good success we can give it that. I used by myself for many patients with prolia, for example. It's a marvelous in dropping the calcium. It failed the low dialysate calcium therapy.
Professor Hisham, last question, if Professor allow me. Why dialysis is successful in correcting acidosis due to uremia, and not the same in patient with lactic acidosis due to sepsis or metformin-induced lactic acidosis? That's the question.
Yes, lactic acidosis is a continuous process of ischemic injury of the tissue. So compensation of lactic acidosis by dialysis is not a cause. And in dialysis as well induce organ stunning. So I expect that ischemic changes to the tissue increase the lactic acid production. You mean that you are using that in patients with multiple organ failure and something like that. So you have to use very prolonged dialysis in general to correct lactic acidosis and treatment of the offending and the cause of multiple organ failure. So CRRT is preferred, or sled with higher permeable dialysis membrane.
Okay, thank you.
Okay, thank you all. We have no more questions and no more comment. Excuse me, Professor Hisham, to close.
Yes, thank you very much. It's my pleasure to be here for the Professor Dr. Yasser, Professor Dr. Yasmine, our colleagues, and the Professor Saeed Khamis, Manali Deep, Dr. Ayam again, and all other colleagues. Hopefully that, as me, enjoyed with this talk to be very informative for you and to be applicable as well. Thank you very much and see you again.
Thank you very much. We all enjoyed this talk really from Professor Yasmine, and we enjoyed your experience, which usually shines everywhere, Professor Hisham.
Thank you very much. Thank you.
I will, many thanks, Professor Saeed, for being with us and for being a very, very active and fruitful participant every session. Thank you for all professors who attended this session. Professor Hayam Al-Aggam, Professor Manali Deep, and Professor Ayman Rifai, who was with us, but I think he has problems in the connection and he left us. Professor Sayed Al-Khashab was also attending this session, but now she's away. Excuse me to close and announce about the coming session about the improving quality of dialysis patient. Unfortunately, Professor Muhammad Nassar apologized, and the topic will be covered by Professor Samir Salli. The same topic, inshallah, will be in next Wednesday, 9 p.m., improving quality of dialysis patient. Thank you, and we hope to meet you all again. صباح الخير.
السلام عليكم.